All right, let's get into it. Today, we're tackling something you see every single day at the pharmacy counter: the patient with a headache. We're going to break down a really practical way to counsel these folks and show how a simple request for a painkiller can actually be a huge opportunity to provide some top-notch patient care. So, picture this. It's Tuesday morning, you're busy, and a patient comes up to you saying they have a splitting headache. They're in pain and they're looking right at you for help. Now, before you even think about reaching for a product on the shelf, your pharmacist brain has to kick in. So what's the very first thing you do? Well, this is your triage moment. You got to put on your detective hat. Your number one job right now isn't to recommend a product. It's to figure out what's going on. Is this a pretty standard headache we can handle right here, right now? Or is it a sign of something more serious that needs a doctor's attention immediately? That's the fork in the road, and you have to make that call first. Okay, so let's talk about the two main culprits we see: tension headaches and migraines. A tension headache? That usually feels like a tight band squeezing your whole head. It's annoying, for sure, but the key is that walking around or doing normal stuff doesn't really make it worse. A migraine, though, that's a whole different beast. It's often on just one side, a throbbing, pounding pain that can be so bad that just walking up the stairs feels impossible. So, how do you figure out if it's a migraine fast? Well, there's this fantastic little tool called the ID migraine screen. It's just 3 quick questions. In the last 3 months, have you felt sick to your stomach? Has light really bothered you? And has a headache basically knocked you out for a whole day? If your patient says yes to 2 of those 3, there is a 93% probability they have migraine. That's an incredibly powerful piece of information you can get in less than a minute. And before we go any further, and I mean any further, we have to talk about this. This part is non-negotiable. Most headaches are what we call primary headaches, like tension or migraine, but your absolute first responsibility is to make sure you're not missing something more serious hiding underneath. This is where screening for red flags is so critical. These are the big ones. You can use the mnemonic SNOP10 to help you remember. But let's just run through some of the most important ones. Is there a fever involved? Any new weakness or numbness? Did the headache come on like a lightning strike, what we call a thunderclap headache? Is the patient over 50 and this is a brand new kind of headache for them? Or is their usual headache pattern suddenly different? If you get a yes to any of these, the conversation about OTC products stops, full stop. You tell them they need to see a doctor right away. So, once you've checked for those red flags and you have a good idea of what kind of headache you're dealing with, your job switches from screening to counseling. And sometimes the most helpful thing you can do for a patient doesn't even come in a bottle. This quote right here really gets to the heart of what we do. A lot of patients are secretly worried their headache is a brain tumor or something terrible. So the simple act of listening, asking the right questions, and then reassuring them, explaining that, hey, it sounds like you have migraine, which is a known medical condition, that can be incredibly powerful. That's how you build trust. And this is where you can really empower your patients. The number one thing? Tell them to start a headache diary. It sounds simple, but it is the best way to start spotting patterns and triggers. Also, don't forget the easy stuff. An ice pack or a heating pad can work wonders during an attack. And for the long haul, talk about regular aerobic exercise. It's been proven to help reduce how often headaches happen. No pills required. Okay, now we can finally talk about medications. Our goal here is twofold. We want to give them something that works fast, but we also have to be super careful that we don't accidentally create a whole new problem in the process. Which brings us to the single biggest trap with any acute headache medication. And I mean anything, from ibuprofen to prescription drugs. Using them too often can actually make the headaches worse. It's a paradox, and it can lead to a whole new headache disorder that you are in the perfect position to help prevent. It's called medication overuse headache, or MOH, and it's a tricky one. It happens when someone who already gets migraines, for example, starts getting more and more headaches because they're using their relief medication too often. The very thing they're using for treatment becomes the cause of the problem. It's a vicious cycle, and patient education is the only way to break it. So, let's talk hard numbers. For your simple, over-the-counter stuff like acetaminophen or an NSAID, the magic number is 15. To avoid that rebound headache effect, they should not be using it on more than 15 days in a month. And you have to stress this point. That's 15 days of use, not 15 pills. Big difference. Now, for other common treatments, the rule is even stricter. When we're talking about triptans, opioids, or any of those combination analgesics, that number drops to less than 10 days of use per month. This is a crucial counseling point for anyone getting a prescription for these. They absolutely have to track how often they're taking them. So let's put it into practice. If someone's taking an NSAID like naproxen, you're going to tell them two things. Take it as soon as you feel the headache coming on for the best effect, and remember that less than 15 days a month rule. For a triptan like sumatriptan, you'll mention it's great for those really bad migraines, but you'll also screen them for things like heart disease, and then you'll hammer home that strict less than 10 days a month limit. All right, let's shift gears for a second and touch on a special population where your advice as a pharmacist is absolutely critical. We're talking about patients who are pregnant. Counseling a pregnant patient is all about safety first. Always start with non-drug options. If they really need a medication, acetaminophen is the go-to. It's just so important to tell them that NSAIDs are a no-go, especially after 20 weeks, and that ergot derivatives are completely off the table. This is a high-stakes conversation that needs crystal clear advice. So let's wrap this all up. What's your game plan? 1. Always screen for red flags first. 2. Be a cheerleader for the non-drug strategies, especially that headache diary. 3. Make education about medication overuse headache a standard part of the conversation. 4. Give them clear limits. Less than 15 days for simple analgesics, less than 10 for triptans. And finally, 5. Remember that follow-up is key. Managing headaches is a journey, not just a one-time transaction at the counter. I'll leave you with this to think about. That headache diary we talked about, it is one of the single most effective, low-cost tools we have. So how could you make it a standard part of what you do? Could you have some printouts ready, maybe recommend a good app? Making that one small change in your practice could make a world of difference for that next patient with a splitting headache.